Hey, well, good morning, everyone, and good afternoon for many of you across the country. So think about this. 512 days ago, we had this first opportunity for Ed and I and Scott Moore to talk about COVID and the effects it was having on us in that time. And I don't think any of us could imagine what has occurred since those days. To go 512 days and the end is theoretically way into the future. But it goes without saying that the response across the nation by our association members, by EMS providers, by healthcare facilities has been beyond amazing. And if you think about 512 days ago, we were trying to figure out how to get N95 masks. What's the rate of infection going to be? Will there be fatalities? Will we lose family members, whatever, and all those things have come true. We've been through a political election. We've had whatever else go on. So to be back today is, in one sense, painful. In another sense, it's rewarding because we can talk about many different things and smart moves are made. I want to thank a couple people before I'm going to toss this to Ed to be Ed. Is the folks at Empress, Cohen and Jim O'Connor, and those guys, phenomenal. We've seen responses across the country helping each other out. We as a collective group went to New York, we went to New Jersey, we've been to Texas, we've been to fires, we've been to hurricanes, we've been to small community hospitals across the country. We've had folks like Jamie Pafford and her Arkansas folks go to other states to do long distance transports. And today we're dealing with the whole issue of vaccine mandates across the country, and particularly here on the West Coast. What are we going to do when this mandate comes down? In our case, in the state of Washington, Oregon, it's October 18th, and we have to deal with the fact that some portion of our staff are not vaccinated. And it's not just us in our field, but it's also going to be others in public safety and whatever else. So it's going to be a challenging time. We're short of staff. We're balancing everything else, and then we're dealing with all kinds of things on a legislative issue. But here's my final word, and Ed, get ready. I'm getting ready to send it over to you, and I know everyone's just tintillating with excitement, is that we did a lot. All of us did a lot. And I couldn't be prouder of our association for what we accomplished as a group, both keeping care of our communities and helping each other. And I want to say this on behalf of us at GMR. We had kind of a horrible event in Tucson. Beyond horrible. And so many of you sent us notes and support for our team members down there. And I never, ever want to hear of one of our people across the country ever being essentially assassinated in a workplace again. So thank you so much. I want to turn to Ed now. Yeah, everyone on this call knows Ed, been our chief medical officer now for 10 years. Ed has been immersed, to say the least, 24/7. Dealing with COVID, and he's provided amazing guidance for us. And in those times we need to be sane, he's been there for us. So with that, it is really sincerely my honor to turn to my friend, our guy, Dr. Ed Racht. Edward.
Thank you, Randall. Hey, everyone. Thanks for joining on a Friday midday or a Friday afternoon if you're East Coast, particularly with this topic. And what I hope to do, I'll tell you what I like the most, and selfishly, what I learned the most from myself are the questions and answers and the dialogue. So I thought what I would do is, as we have done before, I want to catalog kind of where things are, some nuances, some of the changes, some of the things on the horizon, some of the things that all of us are struggling with, and some that a few of us are struggling with. And in the spirit of the canary in the coal mine, we ought to be paying attention to, because there's a good likelihood that they're coming our own way. So with that, Amanda, thank you for loading the slides. If we could move forward, don't set to 2020. So what I want to talk about today is the alpha and omega caused by Delta. Because if you look at where we are, and I think next slide, Amanda, If you look at where we are, so Randy said, 512 days ago we got together. And by the way, we didn't choreograph this. We're not smart enough to be able to say, hey, can we get our slides and talk together? That certainly would never happen. 584 days ago, the first diagnosis was made in the US. Thanks a lot, Randy. I believe it was up in your neck of the woods. All of us in the rest of the United States appreciate you being the leaky sieve to let the virus in. But 584 days ago, this infection, which many of us said, what it looks like, it's very similar to the common cold or to influenza. And then as it started to build, we've been through that over and over again. So the reason I titled this the Alpha and Omega caused by Delta, next slide, is the reality is in our world right now, this just happens to be our colleagues in New Orleans. They are an example of any of us. So search for New Orleans EMS, replace with, insert the name of your entity, your agency, municipal, governmental, volunteer, career, it doesn't matter. EMS is tired. EMS is fatigued. EMS is angry in some areas, and EMS is starting to really get frustrated with what some in EMS see as the potential way out, but others don't see that particular piece. I've said from the very beginning of this, when it got nasty, we are the front of the front line. So we can't say we're the front line of this healthcare pandemic. We're in front of the front line. And it starts in our world when people enter the healthcare system with EMS. So the reason for the Alpha and Omega is this. We know more about this virus, obviously, than we ever have known before. If you look at what we know from the science, take everything else out of it, everything else out. I don't want to hear who you elected for. I don't want you to upload your voting registration card into the vaccine database. And yes, people have done that. The science of this, if we just look at the science of this, the increase in immunity provided through vaccination and the decrease in transmission provided by simple things, barrier methodologies, masks, et cetera, have been making a difference. And I think, again, looking at the science of this, the reason our hospitals are so jam-packed, the reason that our ICUs are packed, the reason that there's a dramatic increase in adolescent and pediatric patients who are sick or critically ill is easy to identify. There's a big chunk of those folks, in some areas almost 100%, in others 98% of the critically ill hospitalized patients are unvaccinated patients. That's not to say they're scummy patients, they are ignorant patients, they are the dumb ones. And I'm gonna tell you a little story about that happened to me yesterday. That's a good lesson, certainly for me, and I think for all of us. That's to say, that's a patient population that chose or was not able to or did not want to embark on a medical therapy, and as a result, ended up being infected and ended up having some significant challenges associated with that. So we're crusty. EMS is crusty. We're crusty, and the worrisome component now, and I'd be interested in other folks' observations, I am increasingly worried that there are folks that 2 years ago would have said, I want to be a paramedic, I want to be an EMT, I want to do that to start my career in medicine, I want to do that my entire career, I want to go to the fire department because I like taking care of patients, whatever it is. I think there's a big chunk of those that are looking today going, I don't want that shit show. No, I don't want to be in there. So we're at a critical juncture, I think, in taking care of our profession, taking care of our people. And I want to try and break that down a little. Amanda? So a couple things in review, but a couple things that I think are important. So I have the advantage or disadvantage, 99% of the time, I think it's advantageous to be able to hear different perspectives. So we have all the way from a 17% vaccination rate in one of our operations up to about close to the high 80s% vaccination rate. So I can understand what some of the perspectives are in different entities that really kind of drive where we are. So I want to kind of assemble some of the observations and some of the things that have come up, and many of you have probably experienced this. So as I jumped with joy, right, holy, thank the good Lord, the Pfizer vaccine received full FDA approval, because as most folks on the call know, full FDA approval means that this vaccine, the Pfizer vaccine, went through the same studies, the same approval process as the antibiotics that are prescribed by primary care physicians, the chemotherapeutic agents used to treat cancers, immunotherapy given to folks with chronic immunosuppressive diseases, all of the medications we give, pain medications, IV, great drugs like procainamide. Hang on, oh, sorry, yeah, not that drug. But procainamide is an interesting example, because the FDA process that approved Pfizer is the same as all of those other approvals. So we have a choice in medicine. Do we go with something that isn't approved at all, or something that keep ourselves from what looks like a promising therapeutic event or intervention? Or do we say, you know what, I don't trust the approval process? So I think there's a subpopulation that don't trust the approval process, even though every other drug that a prescription has been written for them in their lives went through that same approval process. So what are some of the things that we've heard that are frankly challenging in the FDA approval process? You've probably heard it, there are a group of folks that say this is not full approval. They have concerns because the pediatric indication, remember this was approved 16 and up, the pediatric indication wasn't approved. So remember that the pediatric indication came later than the 16 and up indication, right? Actually, than the adult indication, all because CDC and FDA allowed it for those subpopulations. So in order to gather the data, they have to have the data to make the decision. Remember all the Charlie Foxtrot associated with the Alzheimer's drug. The FDA didn't want to go through another event where someone said, you know what, this is a sham show. So having the data, having the numbers is important. The pediatric indication is not a suggestion that full FDA approval is not full. It's another indication, not approval of the drug. The same with boosters. So right now, boosters of the Moderna and Pfizer, for folks with immunosuppressive disease are recommended. So your clinician, consulting with your clinician, making a decision that that third dose would help to enhance the immune response. Because remember, patients with immunocompromise or some kind of an immunodeficiency have a challenge mounting an antibody response regardless, including when that comes from a vaccine. So everyone knows all three of the drugs are either looking at or have developed a booster. My own sense, I think we've been saying it on these calls since day one, is that boosters or recurrent dosing, just like seasonal influenza, seems to be in the cards for what's going on. The virus mutates. The fact that it mutates means that we have to be able to hit what it mutates into the next time around. And the way we do that is with changing the vaccination impact and the antibodies that it creates. Just a quick update, you all know this, I think. Moderna has submitted the majority of their materials to the process, FDA, the CDC process, and Johnson & Johnson is still in the process of collecting, packaging, and submitting that. I also put AstraZeneca on this, and you're looking going, hey, Racht, are you kidding? It's not even approved in the US. So we've got about 38,000 colleagues in our organization. And one of the things that came up today was the fact that we've got a chunk of folks who participated in early vaccine trials. And one of those early US vaccine trials was AstraZeneca. What we had historically said, Novavax, any of the non-Moderna, Pfizer, or J&J, is unless you had those, you were not considered fully vaccinated. So we do know, at least from the AstraZeneca folks, that most of the AstraZeneca trial participants have been unblinded, meaning you've been notified whether you got placebo or you got the actual vaccine. And just recently, a big chunk of those folks have received CDC vaccination cards. So as you're looking at, when we talk about mandates, as you're looking at folks who may have had vaccinations in parts of trials in the US, you may want to consider approving them as fully vaccinated for whatever your mandates are in your particular arena. I say that because there is no guidance, there is no data, and by the way, this gets to boosters, that would support cross indication from drugs. So if I got a complete AZ series, the AstraZeneca series, there's no good guidance for me on whether I should go out and get a J&J or Moderna or Pfizer sequence because of that vaccine. So we'll learn it over time, but we won't learn it right away. The other thing that's important, I don't know how many of you nerds get consumer reports. I'm sure Randy probably does. But I love consumer reports. And one of the things that I go through, particularly when I bought my kids' cars, was the area in the back that had used car reliability. You get little green dots, you get red X's, you get yellow things on different components. The older the car is, the more information they have on whether you should buy that used car, right? We're going to learn the same with these vaccines. The more experience we have, the better we're going to understand the vaccines down the road and be able to make more refined decisions as time goes on. That's good for us. That's good for medicine. That's good for battling this illness as time goes on. The last thing is this. There is an open VAER, so the Vaccine Adverse Event Reporting System, federal program, makes very good sense. You have an adverse event, they want that information reported. And the reason they want it reported is that's the post-approval, post-marketing approval process for the vaccine, so they can follow that over time, just like the used cars in consumer reports. The difference is, if you go into some of the open Vaccine Adverse Event Reporting System documents, those are documents that anyone submits. So they're not documents that are validated. They're documents that start to collect information so the appropriate folks can narrow down their focus and look into things. So if somebody says, look, I got the first dose of Moderna and my left arm literally fell off, scabbed over, and was lying there on the floor. So that doesn't mean that happened. But what it does mean is if a bunch of people lose their left arms, then the right folks, the manufacturer, regulatory agencies will go in and evaluate the data associated with that. So it's good to have VAERS, but it should be viewed in with the intent that it was designed for. Next slide, please. So then there's testing.
Excuse me, doctor,
yes.
If I can, let's talk about a couple quick things here before you go off the vaccine, because I actually paid attention. So,
wow,
yeah, I know.
Jot that down.
So, there's stories out there that that in terms of the J&J vaccine that there is virus in it, and the answer is
incorrect. Well, sorry, there is virus. There's beat up adenovirus. So just like many other vaccines, so the vector, the wounded vector, as some folks call it, they take a pretty harmless adenovirus similar to the common cold, beat the hell out of it, attach some of the antigens so it looks like a spike protein. So when that virus, that beat up virus gets injected, that you end up with antibodies developed toward that. If you look at, you remember the flu mist, the early flu mist, the inhaled flu that was given mainly for pediatrics, didn't want to give them a shot. So that was beat up virus as well. And one of the things that came out, I think it was the second year after that was developed, was to be careful of that virus, that live virus in there, and be cautious on the indication. So yes, it is true that J&J is a beat up adenovirus carrier.
But it is not COVID.
It is not COVID.
Okay, another question that typically comes up and we're hearing, and then we'll roll on to the testing, is the fact that of these, and the second shot, specifically to Moderna and Pfizer, that the number of adverse reactions, be it the 1 day sick up till who knows what, is extremely high.
So I'll answer with the truthful answer first. I have no idea what the second dose sign symptom complex really means, because to your point, Randy, when both of the dual dose vaccines came out, the sense was that your second dose would have more of a side effect reaction. You'd have more soreness. You'd have more of that very normal, as a matter of fact, very beneficial, the fatigue, the low-grade fever, feeling like crap as a result of the inflammatory process. So the first dose gives you the spike protein lookalike, the mRNA. You create the antibodies against that, so you're ready. The second time it comes in, your body says, hell no, no, we've been waiting for you, and we're going to move on. So that soreness, that low-grade fever, and some folks, pretty nasty fever, feeling crummy, is a part of that inflammatory process from the drug. Now, I say that, but with some of the experience, and I'll get back to the used car thing, we're going to learn more over time. There are a big chunk of folks that had a pretty substantial initial side effect profile with dosing and then had nothing with the second. So I think there's more to learn from that. What I do know is that nowhere do people worry about the standard adverse effects, the standard side effects of vaccine dosing, because after all, it is trying to ramp up the immune system. That's an inflammatory response. Every other inflammatory response the body has that discomfort or those things associated with it. So yeah, I think it's a TBD.
Yeah, you might be faster at the answers because I'm losing interest. But anyway, so the third.
Amanda, can you cut him? Do that. It's that red button that we got.
So, third question, final question, and if you're going to address this, then just skip on to address it. The issue comes up if third dosages or if you're J&J of a second dose. And if you're going to talk about that in a bit, just hang on.
Yeah, so I'll give you the quick answer. So the recommendation on booster from Moderna and Pfizer was 8 months after you're fully vaccinated, starting September the 20th. The majority of the variables associated with that decision, just like the decision to wait 90 days after your COVID illness has resolved to get a COVID vaccine, are related in large part to availability of vaccines and the hopes that the first dose patients will have access to vaccine moving forward. So to be determined. If you were to ask me, would you get a booster for any of the three and they came out, I would say absolutely, positively, you bet I'd get a booster. I'll be first in line when it's appropriate.
On to testing.
On we go. So testing, I'm going to be brief here, only to bring up something. Can you at least like mute them or put a thing over his? So testing, everybody knows about testing, and there are two components that are really valuable. So the rapid antigen has been the Binax now, available consumer, available mail order, available as a screening test. Remember, this is a screening test. So its sensitivity and specificity is nowhere near a PCR test. But for population screening, it's an ideal choice. The challenge is, as we get into mandates, one of the number one alternative to, if an alternative is allowed to being fully vaccinated, is an individual who's fully masked at all times, who undergoes periodic testing. And in most cases that I've seen, that periodic is once a week. By the way, not based in any science whatsoever. It's just an interval to do testing to make sure that you don't have a population that's growing. So the rapid antigen test, unfortunately, as of this morning, so in our day job, our organization buys these things. But our last order was 50,000 of these tests to go out nationally. Our plan, because of the dramatic increase in testing requirements from governments, from healthcare systems, long-term care facilities, et cetera, we went to order, and the availability of the Binax now, and many of you are probably experiencing this, is their ship time has become elongated. It's getting harder to get those tests. The Quidel test, QUIDELL, is a similar test. It's a rapid antigen. It is doesn't require an analyzer. The Quidel test was also very available until, for whatever reason, yesterday. There's been a massive increase, according to the manufacturer, in orders for that test. We believe it's related to the testing requirements out there for an unvaccinated individual, because the time frames of being fully vaccinated to being from being fully vaccinated going backwards can be substantial. So what I would tell you is it's important to remember, if you're going to anticipate the need for testing, I would order sooner rather than later. Serum antibodies still TBD. More work ongoing. T cell. So there are a variety of different ways to look at long-term immunity with those, and those continue to move forward. And as of yet, I've not seen a single entity allow antibody testing or T cell testing or any of those convalescent tests as a replacement for being fully vaccinated for those that mandate vaccination. And by the way, as an aside, while some say if you've had COVID, that would be indication enough, we've not found a healthcare system or any of the mandates from governmental entities to allow that either.
Another quick question, brilliant one from me, is on a rapid antigen test, your person gets a positive. In the past, we've repeated the test because of false positive, false negatives. Present standard on a rapid antigen test that you get a positive. What's your thought patterns on retesting immediately?
Yep, I'm glad you brought that up. So yeah, it is. Thanks to Maria for slipping you a little here. Ask these questions, Randy. You'll sound smart. I think the important thing about rapid antigen tests is they do have a false positive rate, and the false positive rate is related to how the samples collected. It's also the testing itself. Historically, what we've done in GMR is if you tested positive on a rapid antigen, we would assume you had COVID, and we would have you wait that appropriate period of time and stay out of patient care and out from around your colleagues. The challenge today is because of the Delta variant. The Delta variant is so much more contagious, so much more transmissible, that the positives that we're seeing in our organization are not the same as before. We have 1 or 2 cases before. Now we get clusters. Now we get 6 or 10 at a time instead of those single cases. So the reality is we could lose a big chunk of workforce very quickly if those are false positives. So what we've done in the majority of our sites is if they do have a positive in that environment, to get confirmatory PCR testing to see if indeed they're a true positive. And yes, we have seen in our organization folks who had documented COVID time 1, who have now tested positive again, who have a second positive COVID diagnosis, and as everyone knows, in both the vaccinated and the unvaccinated individuals. So I'm glad you brought that up, because that's almost more of a logistics issue. It certainly doesn't hurt the patient to keep them out and keep them from being around other people, right? The individual exposed, but it does decrease your workforce in frontline, which right now is a challenge. Does that answer your question, Rainey?
Yes. Yeah, thank you.
Right. Next slide, Amanda, please. So here's the problem. The Alien. I love that movie, The Alien. So when you think about what has happened in the past 2 weeks, I'm going to say 2 weeks, I'll say 2.5 weeks. One of the things we've seen nationwide is a dramatic increase in mandates from hospitals and healthcare systems, government, everybody, to have fully vaccinated individuals that come into their environment. I'm going to talk about some of the mandates here in a second. But if you think about it in this way, this is part of the reason that hospitals and healthcare systems in particular are mandating vaccine. This is a problem with Delta. Delta has about 1,240 times the viral load of the original variants of COVID. So to put that in perspective, if I had one COVID virus and I got onto a bus, I got onto an airplane, I have one COVID virus, I'm on the airplane, everybody else is there, I have the one virus. If I have Delta, I get on that plane and 1,239 of my other one virus buddies hop onto that plane. Now see what you can do in terms of COVID. So the Delta variant, from time of exposure to time of identifying the virus in the bloodstream is about 3 days. Traditional was up to 6 days. So we're actually seeing it in patients faster. There's more of it. It transmits faster. And to my point earlier, what that means is we start to see clusters of individuals who get infected, both vaccinated and unvaccinated. So it's an alien. Our first request was in the state of California, where a hospital said, you must, your folks, your employees who come into this hospital must be fully vaccinated. There are no medical exemptions. There are no religious exemptions. You must be fully vaccinated. At a pediatric hospital, as you can imagine. And if you look at a hospital's point, one individual who comes into a hospital who's infected with the Delta variant, who's spreading a ton of virus, could, if not appropriately protected in that hospital environment, whether it's a practitioner, whether it's nurse, whether it's us going in, could devastate that hospital function or a unit or a comm center much more readily than the previous variants can. So their goal, hospitals and healthcare systems' goal, it's like the movie Alien, right? As soon as the damn thing got onto the spaceship, right? Sigourney Weaver, they're all trying to get away from the alien. The damn thing's under the floor, in all the computer stuff in the engine room. You open up a door to a chamber and there's the alien. Once it's in, once there's infection inside the healthcare system, particularly inside a pediatric healthcare system, the potential is devastating. So it makes sense that they're making this requirement and why they're so aggressive at enforcing that. And I'll point out a couple things here, and then, Amanda, if you could move us forward past Alien there. So here are the changing rules of the game. Mandates, as you know, mandates are requirements. I think requirements actually sounds better than mandate. Are all over the board. I put non-medical in there because for the first time, we're starting to see some interesting behavior in non-medically mandated environments, particularly large structures that have a lot of individuals in the structure, where we never would have imagined that someone would meet us at the door. 911 meet us at the door and say, are your people vaccinated, or do we need to bring the individual outside to you? Now, I would have missed that question on the test, but we're starting to see folks, remember the alien concept, they don't want any of this stuff in that building or in their area. So even some of the non-medical, the business, the non-healthcare facility mandates are requirements are starting to show their face in the EMS world. Healthcare and hospital systems, we've talked about before. There are a lot of questions in many communities about whether the contractor or the vendor, whether this applies to us as EMS. There are a lot of questions if you don't have a contract with the healthcare facility, but you're a 911 care provider. What are they going to do? I've got a 911 patient and they're not going to let me in. That's a violation of all sorts of things. But remember the alien concept. So several healthcare systems have said, if you have unvaccinated individuals who are bringing patients in, we'll meet you outside on the dock. We'll bring them in. So you know what that means in terms of wall time, in terms of turnover time, in terms of getting the patient to where they need to be. That's not an ideal circumstance. So those things are changing literally by the day. I will give you, I'll share an observation. This is only my observation. not available in stores, void where prohibited by law, objects in the air are closer than they appear. When you ask a healthcare system, hey, does this apply to us in EMS? Chances are pretty good they're going to go, no, I don't know, but let me find out. And you'll get a response that'll say, you know what, we didn't include it specifically, but yes, because you're one of the entities around sick people all day long that could transmit from place to place. So we're finding that when we ask the question about specificity, the responses are often, yes, it does apply to you. Governments, state, localities, regulatory agencies across the board are creating mandates in some areas. State of Montana, state of Florida, state of Texas, they are prohibiting those. So depending on where you are, the mandates or requirements vary based on the governmental structure. But here's something that's interesting. For the first time in our experience, Washington, D.C. issued a mandate in a very different way. So where the state of Washington or Oregon or and some of the California or Colorado stuff, they've said, look, you as an EMS agency have to have all of your providers fully vaccinated. DC did it differently. DC said every licensed, certified, registered healthcare provider or unlicensed healthcare worker must be fully vaccinated. So they took it from the organization to the individual. The individual is responsible for him or herself, a different approach. Who's impacted? Are pilots impacted? Are your back office staff impacted? If you have billing folks and somebody brings something to you, supply folks, you're physically in contact, are they included? Determined with each individual mandate. Although the intent here, I got to tell you, after doing this for 2.5 weeks, the intent of every one of these facilities is to decrease the possibility of that alien getting in. So they're going to do everything they can to widen that net. Workforce implications, particularly for folks like pilots. Pilots are very reluctant to get vaccination, certainly under the EUA, because it may impact their medical certification to fly. So their perception is that there may be an implication there. Unions, interestingly, we're starting to see a flip. So many of you know the IAFC, the fire chiefs, issued a statement saying they very much supported vaccine mandates. IAFF, the labor side of the house, said, you need to be cautious when you move in that direction, even though they encouraged vaccination of their members. We're starting to see for the first time the organized labor side of the house, more of them are starting to say, yes, we need to do it. Unfortunately, I have to tell you that it looks like most of them do it when they have a substantial number of their own who are either ill or someone has a catastrophic event. So I think that's a TBD. Method of compliance, do you send a certification to a healthcare facility saying, look, if someone comes in a GMR uniform, we certify that they've been fully vaccinated. You can't require them to put something on their ID. They can choose to do it if they want to. So that's been a little bit of a challenge. And then religious and medical exemptions. Some places, state of California, are very prescriptive, saying essentially it's a documented allergy to the diluent in the vaccine, previous anaphylaxis, that's it. Religious exemption, they identified 2 religions and that's it. Others leave that open for interpretation. So these are constantly evolving, but they have a huge, huge impact on us, because everyone on this call knows if you mandate vaccination of your workforce, will a subpopulation of your workforce say, you know what, it's my right to not do that. I'm out of here. I'm going somewhere else, at a time when everyone's struggling and keep the workforce, keep a strong front workforce in the communities that we serve. Next, Amanda. I think we're almost done here. So when Alpha and Omega become personal, there are 2 camps. There are clearly 2 camps. There's the camp that's following the science. There's a camp that's following beliefs. They are different defined patient populations. They worry about things like their their AMA, their certificate, their certification to be able to fly or not fly. If I'm a female of childbearing age, I worry about my reproductive abilities because there are still questions in a lot of people's mind, even though the data continues to evolve that it is safe. There are still questions in the minds of women of childbearing age appropriately who want to know with absolute certainty. There are also those that want to do the right thing. We have a lot of those. I'm learning. We have a lot of folks that say, I just want to know before I do it. And then I got a powerful message yesterday from one of our union leadership. We were talking about this stuff, everything that was going on. And I talked about, folks who are vaccinated, what they believe, folks who are unvaccinated, what they're concerned about. And I've never thought about this before, but he said to me, he goes, first, I want to thank you for talking about the vaccinated and unvaccinated as equals. I've never thought about that. But he said, the battle between the unvaccinated, the perceived enemy on one side or the other, is half of what's creating some of this dynamic. So trying to help your workforce, your colleagues understand things as equals, regardless of which side of the fence you're on, truly has an implication. Next slide. So a couple things to kind of end with to keep you up at night. The consistency and predictability of EMS is changing dramatically. Rules are changing. The SEMSO, who's been able to kind of create and still is doing a nice job of creating consistency, it's getting harder in areas where there are hurricanes, wildfires, COVID, hospitals are overwhelmed. There are different approaches to different things. And one of the things that all of us need to pay attention to is we got to keep some of that consistency and predictability in our control. Our EMS family, as I said, I'm worried that we're losing a ton of folks out of EMS to other areas, maybe not even in healthcare because of this. Ivermectin, good heavens, it's an anti-worm medicine. Vets give it to large animals to get rid of worms, but there is a subpopulation of patients who are being prescribed this anti-parasitic drug. I put that in there because we've gone through all sorts of drugs. So paying attention to the literature and the harmful impact is important. And then, next slide. Now we can start to really worry here. So here's a problem, right? So this is a study that was just recently published this past spring. The effect of COVID-19 on female sexual behavior. You can read that there. You're all going, that's kind of creepy that Racht does that. Next slide. Guess what? We're all in this together. So when you look at what's going on, and I put these up here sort of tongue in cheek, but not really. If you look at long-term effects of COVID, we've had our first employee who we had to send to fitness for duty testing because of COVID brain fog. His partners complained that he wasn't his normal self. And we had to go through a process to figure out where we would send him, how we would determine, how to apply that right fitness for duty in there. So while I put these up as kind of a ha, 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 no, there's a lot we don't know about COVID. And remember, when you're infected with COVID, the way you develop the antibodies is your organs and tissues are attacked and the body ramps up the immune response. You would much rather get an immune response without having the organ and tissue damage from this virus. So next slide, I think. And I think that's it, unless one more click. And we're at 584 days and we're still learning. I'll open it up. I hope that was at least somewhat helpful.
It was extremely. So I got a couple questions for you, Doctor. Yeah. Here's a great one from Bob McClintock. With the science now supporting that vaccinated people can not only contract COVID, and also parentheses breakthrough cases, and can transmit the disease even if they are mildly or asymptomatic, should it not be recommended that both the vaccinated and the unvaccinated populations be tested if we are truly going to prevent the spread of the disease?
Yes, so I think you're spot on. The only difference, and I'm glad you asked that question, the only difference between those two populations with the Delta variant is that if I get sick and I'm vaccinated, my degree of illness, my morbidity and mortality is demonstrably lower than my colleague who's not been vaccinated, but transmitting the virus, being infected with the virus, all of those things remain the same. We do know that the vaccinated individual doesn't have the same viral load, but they have a viral load and they can transmit it. So you're in the spirit of, both sides are equal, but in a little different circumstance. You're absolutely right with that.
So I'll read this one as a comment from Stephen Worth. I'm not sure you can expound upon it, probably not as well as I would, but probably. But anyway, when you start requiring unvaccinated staff to be tested twice a week and start charging a surcharge on their healthcare premiums like Delta just announced, that will help the vaccination resistance evaporate. And I think that that's a valid point. It takes it a bit more home. But
No,
Ed,
I think
go ahead.
I was just going to, Steve, hey buddy, by the way, I think you're absolutely right. And that's not so much a punitive. I didn't understand clearly what the financial implications of COVID hospitalization across the board are. They are substantial. Listen, we ourselves in our own organization, you probably have too, remember the tobacco surcharge, right? If you smoked, you had a different premium related to that. So I think you're right. I think, what Delta's done is kind of a combo. But I think at some point there are going to have to be decisions made about surcharges for healthcare, about coverage for certain COVID-related events if you choose not to take something that could have prevented some catastrophic event.
So David Tauber asks the question or makes the comment here, how about the next part of that? The vaxxed, unvaxxed can both spread the disease, the illness, should both wear masks at all times in the workplace. And I know we've had a major discussion internally for us. Areas I've been responsible for, I've been re-implemented because of breakthrough cases, masks. Your thoughts, doctor?
So, if I were king for the day and I could wave a wand, I would support exactly what you said. From my perspective, I can wear a mask for 12 hours. Do I like it? No, I don't like it. Do I chew a lot more gum? Yeah, at the end of the day, you chew a lot more gum because of what you're smelling in the mask, right? But it's not hard. It's not something that is catastrophic. There are some folks that are very uncomfortable in that. Masks decrease transmission of viral particles from one individual to another. And we've talked about both the vaccinated and unvaccinated can have viral particles. The vaccinated may have fewer, but they still have some. So personally, myself, when I'm out in the public or in a building, I still wear a mask. I'm fully vaccinated, but I'll take the extra protection.
Sure. Great comment by Rob Lawrence, though he also credits another person with Mr. Johnson with this, is that maybe we stop using the word mandate and we change the terms condition of employment. So maybe that becomes less political. I think that's an interesting one, and maybe codes for that. But here's another one. You and I and others have talked about this. Let's talk about the curve, the bell curve of infection rate, if you would. Specifically, we've been looking at California with the steep peak, and will we have the steep decline because of the aspects of a really highly contagious virus, such as the Delta version, which also has its own predicated positive and negatives. Yes, you do get a higher rate of infection, but then you develop a greater level of herd immunity in conjunction with vaccination. So what are we seeing? What are you thinking?
Yeah, so when I initially heard a couple of folks talk about this is a different curve. This is a very steep spike as opposed to, a broad-based curve. That steep spike, exactly as you pointed out, exactly what we're seeing. We see clusters of infection. We see entire families that light up at once. Is the infection rate so much that you develop a huge number of infected patients who develop the antibodies, and over time, there aren't enough patients then that don't have antibodies for the virus to hop to and infect over and over again. So could this be the flash that then creates a better autumn, right? Where you come out of that and there's more immunity. So I don't know where that's going to go, but I will tell you that a lot more of my colleagues are becoming very interested in whether that is indeed what's happening with this particular viral course, with this important caveat. So, the concept of the herd immunity is enough people, whatever that number is, I'm not smart enough to know what enough is, but whenever enough people have the antibodies, folks will no longer be repositories for virus, and the virus won't have a place to go, and the virus will burn itself out. There's also a concept called thinning the herd. So the peak and the rapid trough is at great expense, because some of those patients, a percentage of those patients in that category, are going to have the adverse events or are going to die from the COVID infection. So while it may lead to immunity, herd immunity, it will do so, if it does, at great individual, personal, and family expense, because that's how that immunity develops.
So here's another great question from Bob McClintock. And Bob, if I don't read it well, my apologies, but I'll try to walk the doctor slowly.
He just learned how to read. If you could send him pictures in the future, it really helps him.
Like my grandkids. So here it is, Bob, doctor. Do you know the comparison of antibody levels in vaccinated population and those who have contracted COVID, natural immunity, i.e. booster, are benign suggested for those 8 months, maybe 6 months, but antibody levels for those with natural immunity have shown the same levels? In other words, I think it's the decay time, or what's the half-life on the IgM, IgA molecules. And I knew the difference between the two.
Yeah, I'm impressed by that, Randall. So another really good question. And I think the jury is still out on which is better, with one exception. If you had to choose, not that I would choose this, but if you had to choose today what appears to be the longest lasting, and again, remember, we don't know necessarily that's why I put T-cell testing. There are all sorts of components of immunity out there, so we don't know exactly which is the most predictable biologic measure which predicts true immunity. But if you look at the best combo is I get COVID, I have COVID, I resolve my illness, and then I get vaccinated. That seems to be a population of folks that have longer lasting levels of antibodies. Now, again, that comes at great personal expense. In order to develop the antibody from the disease, your organs, your tissues, the body has to take a hit. And what we know about brain fog, what we know about I think I've talked about it before. And by the way, good news, I think he's going home. We have a colleague who had a double lung transplant related to COVID. So we don't know what the long-term implications of the immune response to COVID, the longer acting component, or the COVID infection itself. But everybody, Bob, that's such a good question. Everybody's so interested in that, because if you could do a blood test and you could gather immunity data, much as we do with other infectious diseases, you could answer a lot of these tough questions in people who've had the illness versus folks who receive their immunity through an active process through vaccination.
So great question from Joyce Bill, and I want to add on to that if I could, Joyce. So I'm going to tag onto your great question. For boosters, do we need to have the same vaccine as the initial vaccination? Great question. And my tag on, Dr. Ed, is it's flu season time. So any issue, I get my flu shot and I get my third shot of Moderna or Pfizer, or are these two different worlds, or what do we do?
Yeah, so your first question is a really hard question. And I don't know the answer to it, because the evolving data on the second dose in J&J and in the Moderna piece, there's not been a large trial that's looked at cross products for booster third dose or second dose, depending on J&J, Moderna, or Pfizer. So nobody knows exactly which is better in that regard. Theoretically, you would think if I got Moderna 1 and 2 and I got Pfizer as a booster, gosh, maybe I've got better coverage, broader coverage. But that's not necessarily how booster doses work. So remember, each subsequent dose goes into your immune system memory and says, hey, remember me? I'm that nasty COVID thing. Ramp that response up, get stronger again. So would we see more side effects or not? So that jury is out. I know some of my colleagues are recommending cross dosing, so that after you've completed a series of any of the three, you go to another series. Right now, there's no formal guidance on that currently across the board. Flu. So I'm scheduled to get my flu shot Monday afternoon. And I will tell you that the reason behind it, let me be direct, there is no known contraindication for flu shot administration and COVID vaccination at present. Many of us had hoped that down the road, the mRNA approach would include some of the other respiratory viruses so that it would be a one-shot takes care of all. So there is no current contraindication to getting both. I will tell you from a practical standpoint, it would be disastrous for us as an EMS profession in the flu season, which could be nasty this year because we don't have a lot of data on last year because flu season was pretty mild last year. It would be disastrous for us to start having a big chunk of employees that have upper respiratory infection, shortness of breath, some fever, some chills. What does that look exactly like? So minimizing your chance of seasonal influenza so it doesn't create a diagnostic dilemma. Because here's the reality, when folks start having those symptoms, probably starting now, then you'd want to test them for seasonal influenza, you'd want to test them for COVID to see which of the two they had. So minimizing your chance, I think a chance of seasonal influenza, I think makes a lot of good sense. I'm certainly going to do it.
Excellent. Well, listen, I want to thank everyone today. We've come up to the top of the hour. My guess, Ed, will be back next month. I think we will there'll be some updates. Oh, well, one question from Ms. McGon Johnson. Is the booster shot exactly the same thing as the initial shot and the second shot? So is your third hit going to be the same stuff?
So I don't know the answer to that question, but I think we're going to know the answer to that question as the FDA processes move forward. So remember Pfizer, who I know the most about, I don't know much at all about, I've not seen much on Moderna or J&J. There was initial sense that they would slightly alter some of the mRNA approach because Delta was slightly different than the other variants. I've not seen, so I can't answer that with any degree of certainty. I'm going to guess here, that future doses will have enough to create that boosted response, but we'll also add in there anything that needs to be added to tackle any kind of change in the variant so that it's more effective in a broad sense. So you're talking about powerful, meaning, targeting exactly what the vaccine is meant to target, and then adding something that would broaden its spectrum.
All right. Listen, I want to also add thanks. I mean, again, we give each other bad time, but you make me feel good about life, and you really help all of us through some tough times.
You know what, Maria? He's drinking again during the conference calls. You can tell.
So I'll point out we've got a couple additional, thanks, Ed, great. HR will be calling, really. So a couple of good things. We have a couple of great webinars coming forward. One will be about mandatory vaccination and accommodation requests. Scott Moore is going to try to walk us through that gentle line. We'll also have a future one on, very quickly, talking about the impacts of wall time, holdups at EDs, and all that's affecting all of us. Right and left, how to get that, and then about our reporting tips for EMS. Again, Scott Asbell, Brian Werfel. So we appreciate you, everyone, taking time today. The turnout was huge for our call today. Ed and I are honored to do this. We'll be back. I'm going to guarantee we'll be back next month to see where we're at, and hopefully it'll be more positive action. So here's all I ask. Please have a safe weekend. Please take your people who are not vaccinated and have that heart-to-heart talk with them. We're going to get through this. We're going to continue on, but I don't want to have any more calls where we're talking about another loss of life. And to all of you, thank you. Thank you for participating. Thank you for taking care of your communities. And
thank you all. Happy Friday.
Thanks.